Thank you so much to the DRNI for inviting me to do this presentation today. I always welcome any opportunity to talk about CST and CR. And thank you to everybody for coming along as well. So it's great to see that there's so much interest in the topic. Okay, so the interest in these kinds of psychosocial interventions is increasing here in Ireland and indeed increasing worldwide. The Irish National Dementia Strategy, much like many dementia strategies worldwide, prioritised early intervention, timely diagnosis, and appropriate interventions for that early stage of dementia. So people are encouraged, to go to their doctor as soon as they start to notice any changes and to get an early diagnosis. But then what, right? So what we have found in some instances is that where early diagnosis occurs, sometimes there was this treatment gap being observed where the early interventions were not properly sort of set up or available to people at the early stage. So that's where these kinds of interventions come in, the CST and the CR. So, in terms of medical intervention, I'm not a medical doctor, so I can't speak in any way comprehensively about pharmacological or drug-based interventions. But I think it's fair to say that we would have hoped that drug-based interventions would have been further advanced than they currently are. So with the absence of this sort of a pharmacological cure and the increasing numbers of people who are experiencing cognitive decline and dementia, it's really highlighting the necessity of focusing on alternative sort of lifestyle-based or psychosocial approaches to managing the symptoms of dementia. So of these kinds of interventions, what we really want to focus on is we want to focus on interventions that are evidence-based. And this means that there's a strong body of research that shows that the intervention works. So these are two evidence-based cognitive interventions, and these are both designed for people in the earlier stages of dementia. So they're very suitable to be made available to people post-diagnosis where that diagnosis has been made early in the disease course. So cognitive stimulation therapy then is the first intervention that I'll speak about, and that was developed by Amy Spector and her colleagues in University College London. And the second intervention, cognitive rehabilitation, was developed by Linda Clare and her colleagues in Bangor University in Wales. So we'll start off with CST, with cognitive stimulation therapy. So what is CST? Well, it's an evidence-based group intervention, and it's designed for people with mild to moderate dementia. Typically, the group would consist of about maybe 8 to 10 people with a diagnosis of dementia. And they would work together in a group with 2 facilitators, so 2 CST facilitators. Usually the intervention is offered across maybe 7 weeks, so 2 sessions a week for 7 weeks, but it can also be offered, 1 session a week for 14 weeks. It really does depend on the resources of who's delivering the intervention. And what CST really does is it provides a social environment where people can come together with other people who are in the same kind of situation as themselves. They can get social support from that situation, but then the facilitators across a sort of 60 to 90 minute session will run a session that's cognitively stimulating. So they'll provide sort of general stimulation for people's thinking and memory across a number of different themes. And sometimes when we see the benefits of CST, it's hard to really figure out, is it the social bit that's really beneficial or the cognitive bit that's really beneficial? But in my experience and in my opinion, I think the two just come together really nicely, and both are beneficial to supporting people at this stage. So this is just a snapshot or a screenshot of the CST page. So it's CST Dementiacom is where you'll find all of the information about CST. And this page just outlines what the CST sessions look like or what they entail. So you can see there on the screen, there's the 14 CST sessions, and you can see that each session follows a general theme. So the theme of session 1 is physical games, session 2 is sound, and so on and so forth. So what this means is that the facilitators, there are manuals. So this is my manual here, and I'll talk to you a bit more about the manuals in a moment. But there's a manual that stipulates the themes and then provides options for the facilitators for what they're going to run or what they're going to do in those themes. So, it can provide suggestions as to what facilitators may wish to do. It really is up to the facilitators themselves what way they want to run their groups, because they will know who is in their groups and they will know their group better. So there is a bit of flexibility built into. So while it's a prescribed sort of an intervention, there's flexibility built into it that people can adapt it as they need to or as they see fit. So the standard CST then is 14 sessions. There is also a maintenance CST manual, which offers an additional 24 sessions. So this came out of demand. People were really enjoying the 14 sessions and feeling like they didn't want the intervention to end there. So where resources are available, maintenance CST can also be offered. I'm just going to give you a little example of one of the CST activities, just to give you a taster for what it's like. So this is the activity that's the Faces and Scenes activity. So with this activity, we're presenting pictures of famous people, and we're asking sort of questions about those. One very important aspect of CST is that we focus on opinion rather than fact. So we don't want to put people on the spot by saying, who's that? Do you know what their job is? Do you remember when that person was president? Because I guess it's probably self-explanatory, but you're working with people who have memory problems. So you really don't want to ask them questions like, do you remember? Who is that? And when you ask people about facts, that can be putting them on the spot. It can make them feel uncomfortable. And, when somebody is nervous and uncomfortable, their cognitive performance dips anyway. So with CST, all of the sessions are designed to really just focus on people's opinions, and you're promoting implicit learning in this way. It's not really obvious that people are learning. If you get feedback in a session where somebody says, oh, this feels like school, you need to reevaluate, because it shouldn't feel like school. It should feel like a fun group where you're getting together, you're having a bit of fun, and people there's conversation flowing. So for this activity, I could present these pictures on the screen, and the kinds of questions I would ask my group would be, do you think these people have anything in common? What do you think their jobs might be? Do they look like they would have a certain kind of a job? Do you think they're attractive? That's always a good question to ask. And there's a bit of crack then with that kind of a question. Are they nice people? So people will have, although, they may sort of have an inkling or a sense of who the person is in the picture, they will have a sense of whether they like them or not, even if they can't remember their name or they don't know exactly who they are. They might be like, oh, that person looks familiar. I think that person might be on television. And then, invariably during the group, at some stage, somebody will say, oh, I know who that is. That's Donald Trump or whoever. And that will then promote more conversation. But it's important as the facilitator just to focus on the opinions and asking people, what do you think about that? Do you think that? So what do you think? Do you think? Do you like? Can you think of any similarities and differences between them? Is there anything that, even if somebody said, oh, that's the president of America, you could say, do you think it would be difficult to be the president of America? These kinds of questions. So that's just one example of the activities, and the same sort of key principles apply to each of the activities, in that you're promoting errorless learning, you're promoting implicit learning, you're trying to create connections and trying to get people to think in ways that they wouldn't normally think. Instead of rehearsing information that they rehearse all the time, trying to get them to think about things in a slightly different way. So there's the three manuals then. The first one is the standard for the standard CST sessions, that's the blue manual. The second one is for the maintenance. Now the maintenance manual, if I was to recommend one, I would recommend only buying the second one, because it has all of the original 14 sessions and it has the maintenance sessions, and it also has a free DVD, although I have nowhere to play my DVD because I don't think anybody has DVD players anymore. But it is helpful in that it has all of the sessions. Then the third manual there is interesting. So this is the individualized CST manual. This is for where, if an individual has engaged in a group and the caregiver or the family member feels like they would like to continue it on with them on a one-to-one basis at home, this manual can come in helpful or handy for that. The evidence in terms of the third manual isn't conclusive just yet, but certainly, something is better than nothing. It can be beneficial. So what about the CST research then? So a number of randomized control trials and small group-based studies have identified that CST is beneficial for cognitive function. So when comparing people who have been in a CST intervention group compared to a treatment as usual or an alternative group, we observe these significant improvements in cognitive function for people who have had CST. And it's significant improvements in these sort of measures of cognitive function, so objective measures of cognitive function, and quality of life has also been shown to improve. What we don't see this kind of generalizing to everyday functional ability. So I suppose people wouldn't rate that their functioning at home would be much different, but we do see cognitive improvements. And interestingly as well, when we compare the cognitive improvements to dementia medication, so the dementia medication are the cholinesterase inhibitors. There's a study there that looks at that compares CST to the medication and found that in terms of improving or maintaining cognitive performance, CST is as effective and in some cases more effective than some of these cholinesterase inhibitors. So if anybody wants to look up a bit more information on that, there's a reference slide at the end, and it's reference number 2 for that one if people are interested. So overall, a strong body of evidence to show that CST is evidence-based in its ability to improve cognitive function. So not much work had been done on CST in Ireland. So myself, with the support of the Alzheimer's Society, we ran a study in 4 pilot sites. So you can see there on my map, it was Sligo, in Galway, Dublin, and just there on the Clare-Tip border in Ballina. And it wasn't a randomized control trial, it was just a pre-post study, but even still, we were interested in seeing whether this could be something that could be done in the community with people with early stage dementia, and we found that our results supported the previous findings. So we did find it beneficial for our participants. Recommendations for CST overall then. So CST has been recommended by the NICE, the Social Care Excellence Guidelines in 2006, and they reiterated this recommendation again in 2018 in their next publication. And it's been recommended by HICWA and the World Alzheimer Report also. CST in Ireland, I suppose the real interest and an increase in the number of people being trained has only really been happening over the past 2 years. So at the moment, I'm the only accredited trainer in Ireland, but we would be hoping to get more trainers coming on board soon enough. But we have about 120 people trained to date, and there's many more trainings booked for this year. But if anybody is interested in looking up information about training, Engaging Dementia are the website, and if you just click that link, I'll make these slides available so you can click that link to access more information about the CST training. So moving on then to cognitive rehabilitation, I'm keeping an eye on my clock here because I could talk about this all day, so I don't want to go too far over time. So with cognitive rehabilitation, this is just a little bit different in that this is an individualized intervention. So it's not group-based, it's a one-on-one intervention, and this is much more goal-based. So where CST is a little bit more prescriptive and everybody does the same thing and goes through the same sessions, CR is very individualized, and it really just works on the goals of the individual. So the intervention could look radically different for all of the individuals engaged in the intervention. And it's been shown to be beneficial for people with acquired brain injury, mild cognitive impairment, and early stage dementia. And in my experience with this intervention, I really would say it definitely is more suited to people in the earlier stages because it's a much more interactive intervention, and it requires a lot more engagement and a lot more interaction and feedback from the participant. So it really is better suited to an individual who really has that capacity to work with you at each stage of the intervention. What the CR sessions look like, an individual would identify 2 or 3 personally relevant goals using a goal setting tool. And from there, then the therapist would develop an intervention plan for the person. So this requires experience in developing intervention plans. So again, kind of comparisons between the two. With CST, it can be run by anybody who has experience with people with dementia or anyone who has done the training and has the manuals. Whereas with cognitive rehabilitation, the requirement or the recommendation would be that it's only run by occupational therapists or qualified psychologists. So it's a little bit more, you need a bit more experience in the intervention planning piece. It's usually run over around 2 or 3 months, around 8 to 10 sessions across those 2 or 3 months. And the sessions are around 60 to 90 minutes each. The kinds of goals that people would identify would be things like, I worked with a lady who had a number of grandchildren and was beginning to mix up the names of the grandchildren and really wanted to work on that. So we worked on face name recall for that goal. Number recall, people might want to recall phone numbers or PIN numbers or, car registrations. Things like using memory aids can be an important goal as well, to try to set up the environment to be more conducive to supporting the person's memory. And also technological kind of goals like using a mobile phone or using a sat nav, these are all quite common. And even these are the goals that participants that I worked with would have identified, and I often see these repeated in other published studies as well. So there tends to be kind of similar goals that people identify that they would like to work on. So this is a little bit of a busy slide, but I just want to go through it just to show you an example of what a CR activity could look like. So this was a session plan that I drew up for one of my participants for the face name recall. So the item for training is I'm showing my participant a photograph of her grandchild, and I'm saying, okay, so his name is Brian. This is the one that we're working on for this session. For each of the to be remembered items, I would usually work on a mnemonic with my participant, and that's just getting the person to use visual imagery to help them to recall the information. For this one, we would imagine, you try to make up something like a little bit funny as well. So myself and the participant had a bit of a laugh with this one, where she would imagine when she looked at the photo, she would imagine his head sort of blowing up like a balloon and then coming back down again. And we imagined that it was his brain getting really big and small, and we said, okay, brain sounds like Brian. So when she imagined the picture of the head moving, she thought of brain, and that prompted her to remember Brian. So the mnemonics can be anything, but it's good to work with the participant on picking those. I used, simple prompting procedures, so cueing with increasing assistance, where I would present just the first letter of the name in the learning trials and see if the participant could finish the name. If not, I would present the second letter and so on until the participant could identify the name. I did also use an errorless learning technique. So ideally, you want to minimize the number of errors your participant makes, because making errors makes people feel uncomfortable, but also sometimes they remember the errors better than they remember the correct information. So reducing errors is really helpful. It's just really easy. You just say to the participant, look, if you don't know, tell me you don't know, or just don't say anything. And if a second passes where you haven't said something, I'll get in there and I'll prompt you with the correct answer. For consolidation and testing there on the second last line, I used a technique called spaced retrieval, which is where after the learning trial, I would ask the person to restate the information immediately. Then I would leave maybe about 30 seconds of a gap and I would ask them again. Then after a minute, I would test them on it again. After 2 minutes, I would test them on it again, and so on. So this is a technique that helps to consolidate to be remembered information. So it's called spaced retrieval. And obviously we'd be doing things in between. So if it's a 10-minute gap, we would be doing things in between, and it would be, in or around 10 minutes. But this is helpful to get people to really consolidate the learning of that information. And then data needs to be taken on this. So you need to record during the test sessions whether the participant is getting it right or wrong. If the performance is not improving, then you might need to modify the intervention to improve the performance. So when I was running these CR sessions with my participants, I found that there's so much information available on CR, but there wasn't really one quick kind of a go-to place. So with the support of the Institute of Neuroscience, the NEIL program, and the Alzheimer's Society, we put together this manual, myself and a colleague of mine, and it's just really identifying strategies and techniques, because the intervention can't be prescriptive and it's so individualized. It's difficult to pre-plan, but this manual just outlines things like the guiding principles, tips for recall strategies, tips for the kinds of interventions that I would do for face name recall, number recall, and so on. So hopefully it's helpful in just helping people to identify those kinds of strategies. And I've made that manual available as well. There's a link at the end of the slides and people can download that manual for free. So what about the research in relation to cognitive rehabilitation? Just keeping an eye on my time there again. I'm not going to go too far over. I don't have too many slides left. So the evidence for CR comes from 2 randomized controlled trials and a number of single case and small group designs. And what's been shown is that CR significantly improves people's goal performance and their satisfaction in their ability to carry out these goals. So it improves people's subjective perception of their performance, but it also improves their actual performance as rated by their therapists. There's some evidence to suggest that it also improves quality of life and caregiver quality of life. Interestingly, though, the single subject design studies do show cognitive benefits, but the randomized controlled trial studies didn't support this. So in the RCTs, they saw significant improvements in goals, but not in those sort of objective measures of cognitive function. So really, it just depends on what you're really looking for. For CR, it's going to be more everyday functioning that's improved. For CST, it's going to be more general cognitive performance that's improved. Again, myself and some colleagues from the Institute of Neuroscience and from the Memory Clinic, we ran a Cog Rehab study with 3 fabulous participants with early stage Alzheimer's. And what we found is, so if you look at, I know the information at the bottom might sort of not be too meaningful for some people, but what we found was for our first participant, we didn't see cognitive improvements, but for our second and third participants, we really did. So from baseline to post-test, baseline was week 1, post-test was week 10, and follow-up was week 16. So for participants 2 and 3, we saw some impressive improvements that were maintained in terms of cognitive performance over time. And what we really found was the earlier people engaged with the intervention, the better. So our participants 2 and 3 had higher levels of cognitive performance at baseline, and this really stood to them. They were really able to engage with the intervention, and we did see that cognitive improvement, and also the other kinds of improvements that we've observed in the other studies. So just interesting there that, it's difficult to say, looking at randomized control trials, exactly what individual improvements can be observed. But for us, we did conclude that the earlier, the better for CR. So for recommendations for CR then, it's clinically effective in enabling people to improve their everyday functioning in relation to their own personal goals, and which can be, it can be more important for some people as opposed to general improvements in cognition. The best performance gains, just to reiterate that again, were seen in participants who had higher levels of baseline cognitive function. There are no current training workshops at the moment available in CR, but I am developing a training workshop, and it will be ready to go for the summer. So if anybody is interested in finding out more about these training workshops, I leave my email there on the slides. And also there's the link. It just brings you to my ResearchGate page, and the CR manual can be downloaded from there, from the ResearchGate page, if anybody is interested in that. And there are some references, and right on time, I think. Thanks very much.
That's great. Thanks very much, Michelle. That was really interesting and really clearly explained. I mean, you just, yeah, a really nice summary of both the CST and CR, so well done. So we have some questions there coming in. So first question is, how do you measure cognitive improvement?
So for the randomized control trials, what would happen would be at baseline, a number of cognitive tests would be administered. So tests like the MMSE and the MoCA. And then after the intervention, these cognitive tests would be administered again, or kind of alternate forms of these tests. And the intervention group would be compared from baseline to post-test. as would the control group, and then also the intervention group scores would be compared to the control group scores. So kind of two different ways of determining whether the cognitive scores improved over time.
Yeah, great, thanks. And I think you were saying there as well about, you know, the difference between improvement on a test versus improvement in day-to-day life. I think there's quite a difference sometimes, isn't there? So, you know, sometimes people will notice an improvement to the test, but not in everyday life, and then vice versa. You can notice an improvement to everyday life, not in a test. So
Yeah, absolutely, Carol. You've actually made a really good point there. So for some, when we're trying to determine the everyday functioning, we would just ask people, you know, it's a subjective rating. You just sort of say to the person, how do you think you're doing cognitively? And you would ask them that beforehand and afterwards and see if their scores differed for those. Yeah.
Yeah. And would you have, sorry, this is just a question from me now, but would you have asked spouses or, you know, family members how they, did they notice any improvement, or was it generally the person themselves was taking part in the program?
It varies from study to study, but for anything that I have done, yes, I definitely would. A lot of the cognitive rehabilitation, they would also ask caregivers, because there's an assessment, the Mars assessment that Linda Clare developed, that has an informant version. It has the version for the person with dementia and also for an informant. So yeah, it is very common, because in some instances, the person's awareness of their own ability can be variable. So in some instances, it's really helpful to also ask the family member or the carer of the person. Yeah.
Yeah, great, thanks. So another question, if CST is a group event, what has happened in the past year? So obviously with COVID, I don't know if you're aware of people running sessions online.
Yeah. So we've had to, I mean, in the beginning, you know, the International CST Trainers Group got together and said, oh, we'll just pause CST, because sure, look, everybody thought this would be over in a couple of months. And then a couple of months passed and we said, no, actually, we can't pause the training now. So what we'll do is we'll try to facilitate it to be delivered virtually. So yes, like worldwide, a number of intervention sessions have happened virtually. And actually we're due to catch up in about 2 weeks as a group to try to evaluate how well that's working. And it makes it a lot more accessible for people. So there are definitely pros to it, particularly when you think about transport and accessibility for people to get to these intervention sessions. But I wonder, is it as beneficial, because you have you know, a Zoom call is just not the same as sitting in a room with somebody. So yeah, we're going to catch up soon to evaluate those, but it's happening virtually, so questionable how effective it's been.
Yeah, it'll be interesting, actually, won't it, to see, you know, there's been such a change over the last year. So question here from someone, when they're kind of giving out to their children, they end up verbally going through loads of family names before they finally get to the guilty party. Is this normal cognitive behavior under stress? So that's a good question.
Yeah, that absolutely. I mean, that is normal cognitive behavior under stress. I think, I mean, I remember my mom does it, my husband's mom does it. You know, you'd even be naming the name of the dog or the cat before you're getting to the person. So this is something that we would quite commonly see. You know, where it might become problematic is if it's not just that, if it's, you know, if you're not remembering the names in all kinds of situations or scenarios, or if it starts to, you feel that it's more significantly impacting your ability to function, that's when it can be flagged as something that could be a bit more problematic. But yeah, absolutely, under stress, we all have those kind of like, oh, what's your name? I find it now as well. The more names you have to go through, the more difficult it gets.
Yeah, absolutely. And again, something I've seen, you know, in my own family as well. Yeah, very common. Yeah. Someone asked here, are there therapies available in Dublin?
So in terms of who's actually running groups, I would check in with the Alzheimer's Society. So I think there are groups running in different areas. I know there have been groups that have been run in Dublin. Once people are trained to deliver CST, then I'm not sure how much CST is actually delivered after that. I don't really get to kind of keep track of that. I just train the trainers and then they go off and do their thing. But I would maybe contact Engaging Dementia or the Alzheimer's Society, and they would have a bit more information about where the groups are available.
Yeah,
there should be CST groups up and running in Dublin.
Yeah. And I wonder as well, you know, Understand Together, they have a website, and Dementia Pathways. So they might be two other sources. Now, I'm not 100% sure myself, but I suppose just for people to have, you know, a few places they can check, they might be.
Yes, Dementia Pathways, actually, that's
Dementia Pathway. So it's demenciapathways.ie. Yeah, if people are interested in in that. Great. So, and again, a question on how does one access the program? So again, that's a similar question. Could you post the link to the manual again, please? So that's going to be on your slides, isn't it?
It's on the slides, yeah. So if people can access the slides, Carol had provided the link to those. So if you access the slides, the link will be there. And if people are having difficulty that way, if you can find me on ResearchGate, and it's on my ResearchGate profile, or you can email me.
Yeah. So the slides will be on our website, which is demencianetwork.ie, and under the resources tab, you'll find all the slides from all the webinars there. Or you can just email me if you have any problems finding that. So someone asked here, if the person with dementia does not acknowledge they have dementia or does not believe there's anything wrong with their memory, is it possible to include them in a CST session or cognitive rehabilitation? And then are there any tips for encouraging the person to participate if they do not want to?
This comes up quite a lot where, you know, the person either doesn't have an awareness or isn't ready to admit it or kind of, you know, engage with these kinds of interventions. So what can happen is sometimes, particularly for the CST groups, the group that was run in Galway, they referred to it just as kind of brain training and advertised it for people who had any kind of memory problem. So it doesn't necessarily have to be advertised as something for somebody with Alzheimer's disease or with dementia. But it's important that the facilitators are aware that there's a person, you know, interested in coming into the group that isn't aware of their diagnosis, so that the group then can be very much tailored towards anybody with memory problems. And to be honest, that's how the groups generally are targeted anyway. You know, some people might mention in the group, oh, I have this disease, but generally people would say it's really nice to meet other people who have memory problems like me, and it's talked about in more of a general kind of a way, where if the individual has no awareness of their memory problems at all, it's probably going to be a little bit more difficult to try to get them to engage in something like that. And maybe the cognitive rehabilitation may be a bit more suitable, where you're just saying to the person, look, we're just going to get a bit of help, but you know, is there anything that you feel around the house that you could be doing a little bit better, like maybe remembering your appointments or things like that? And that might be a way of getting people to engage a little bit more. But I guess, you know, it's about trying to help the person to understand that, you know, their memory has changed a little bit, and that you just want to help to support them to be the best that they can be.
Yeah, great, thanks. The question here, what if the person thinks such exercises are silly when they're suggested?
Yeah, I think this comes up probably more with CST, because some of the sessions, if they're not facilitated well, can seem a little bit silly or can seem a little bit childish. So really they need to be facilitated in such a way that doesn't happen. But if the person doesn't like the intervention, you know, it may not be for them. And that's why I think it's really important for us to get to a place in Ireland where we have a suite of interventions available for people, that CST isn't the only thing that's offered. Because if the person doesn't like it, there's no point in forcing them to go through it. If they really don't want to do it, you need to try and maybe reassess and see, is there something else that they could do? Because really the cognitive benefits come from the person enjoying it and engaging with it willingly. If they're hating every minute of it, that's probably increasing their stress levels and probably, you know, taking away from the benefits that they might get from it. Yeah, so if they think it's silly, maybe try a different approach.
Yeah, great, thanks. Someone asked here, with elderly people being vaccinated soon, will these sessions now be commenced again shortly in group sessions? So I don't know if you're...
Yeah, I mean, I really hope so. That's the hope, but it's just been so unpredictable. Like everybody's sort of afraid to commit to or to promise anything because it has been so unpredictable up to now. So as soon as possible, we will be aiming for getting these back up and running in groups. But in terms of when, a date for that, it's very unsure.
Yeah. Someone said here, we have a CST service in Our Lady's Hospice and Care Services, currently facilitating it virtually, but hoping to get back face to face. So yeah, so there's an example of a virtual session taking place. Yeah.
Yeah, I did the training with the guys in Our Lady's Hospice, and they were brilliant. So I'm delighted to hear that that's on offer.
Yeah. Question: how beneficial is it for people to join groups only with others with dementia? I would imagine it might be quite disheartening.
Well, what we say to the facilitators as well is that where possible, you really need to have a group of people who are functioning at a similar level. So the intervention is really designed for people with mild to moderate, but that can be quite variable. So ideally, you would have like maybe a screening session, or ideally it would be a situation where you know participants and you can group them in smaller groups with other people that have similar levels of functioning to them, so that the person isn't, with somebody else in a group that's performing at a starkly different level. It's too hard to pitch your activities if people are too different as well. So you try to have that similarity. In terms of everybody having memory problems or everybody having a diagnosis of dementia, we find that it's not disheartening for the group members. In fact, my experience across the board has been people have been saying, I thought I was the only one in the world with this thing. It's so great to meet other people who are in the same situation as me. And that social support and the bonding starts to happen really early on in the first kind of 2 or 3 weeks of the session. And often we find that people remain friends and they're meeting up for coffees for months and years after the intervention. So it's more supportive from that point of view.
Yeah, great. Some people are asking about the Making a Difference manuals, where they're available from.
They're available from Hawker Publications. So the link to Hawker Publications was on the slide with the picture of the 3 manuals. I don't think, I have nothing to do with kind of the sale of them or whatever, but I don't think they're too expensive. I think they're around 17 or 18 euros. But Hawker Publications, HAWKER, is where they're available from. The link is also on the CST Dementia website, so you can access the manuals from there.
Okay, great. Someone asking about the recording of the webinar today. Yeah, so it'll be on our YouTube channel. So if you go onto YouTube and look up Dementia Research Network Ireland, you'll find it there, and it'll definitely be there by the end of the week, hopefully by tomorrow. Where someone's asking, where do referrals normally come from?
That's a difficult one as well. We really need to get to a position where referrals are coming from a number of different sources. It varies from group to group, so I'm not sure exactly, and perhaps somebody on the call, even if that person from Our Lady's Hospice could maybe comment on that. But the referrals, if a person is attending the memory clinic, the referral could come from there, or if they're attending an Alzheimer's Society service, they may be able to access groups that way, but there is no uniform way that referrals happen. Some people just contact a place and inquire about how to access the group.
Yeah, and so somebody is saying there from Our Lady's Hospice, our referrals generally come from geriatricians in the acute hospitals.
That's brilliant. Yeah, it's great. It would be great if that's happening, if that was happening countrywide across the board, but yeah.
Yeah, and they're currently focusing on formalising the referral pathways.
Excellent.
Yeah. And so, because you were saying, Michelle, that it's only really in the last 2 years, I think you were saying, that CST has really been available. Is that right?
Yeah, it was a bit variable up until that. Definitely sessions were run, that the work that was done on the paper, the pilot sites, that was back in 2013, 2014, I think. So there have been pockets of it happening here and there, but in terms of building up a mass of individuals who are trained to deliver the interventions, really we're just seeing a massive increase over the last 2 years. So hopefully we will see that, continuing to increase, and then the interventions being made available more broadly countrywide.
Yeah, because I know the National Dementia Office have done a lot of work on the post-diagnostic support, so it fits in with all that, and making sure that these interventions are more readily available, that there's referral pathways in place and all the rest. So it ties in with all that. Someone's asking about the CR summer workshop and looking for your email address. I don't know if you're happy to give that out, Michelle. You might type it in there in the, oh no, actually you're sharing a slide, so it might be difficult for you. Yeah, I can do that.
it's michelle.kelly@ncirl.ie. And I actually had the email address that's shared in the slides as well. So if people that want to access the slides, it's there.
Okay, so I'll just send that to everybody now. Michelle.kelly@ncirl.ie. Okay, great, thanks. So a question here about OTs. So do you recommend occupational therapists to gain extra specific CST training before running a group? Or is it enough to be qualified? They're qualified over 5 years with experience in working with dementia and using the manuals to help facilitate CST groups?
Yeah, so for the CST and the cognitive stimulation therapy for the group one, the recommendation would be that people would attend the CST training. But in terms of qualifications, really all you need for CST is just to have worked with people with dementia previously, or even caregivers could do the training. So there is no standard or lower level of qualification that's required for CST. So yeah, absolutely, that occupational therapist could go to attend one of the CST trainings, use the manual, and run groups. For the cognitive rehabilitation, yes, occupational therapists would also be qualified to run CR, and certainly if that person has experience with a person working with people with dementia, and would need to maybe supplement their knowledge with reading some of the CR literature and the CR manual. But yeah, in terms of CR as well, that person would be qualified. Yeah.
Great, thanks. And someone's asking, do you have to pay to attend either CST or CR sessions?
The sessions are normally delivered for free, as far as I'm aware, but I'm not sure. Potentially, maybe some groups, there may be a small fee, but as far as I'm aware, any of them that I'm aware of so far have all been free to attend.
Yeah, great. And a similar question to the one before, which is, would it be suitable for a healthcare assistant to complete the training to run CST in a nursing home? So from what you said, it sounds like...
Yeah, actually the majority of people that we train are healthcare assistants in nursing homes. Yeah, so definitely.
And then again, on a similar theme, can nurses and other professionals be trained in running CR sessions?
I mean, my opinion on this is yes. I spoke to Linda Clare about this a number of years ago, and she was maybe a bit more strict about it and said it really absolutely has to be just for CR. It has to be just an OT or an appropriately trained psychologist, like a clinical psychologist or behavioral psychologist. But in my opinion, yes, if you have experience in devising interventions, in identifying goals, and in running these kinds of interventions, I think that we need to be able to facilitate these interventions being made available. So the fewer barriers we have in place, the better. So I would say yes. But if that person wanted to catch up with me and we could chat about it in a bit more detail, I'd be happy to do that.
Great, thanks. And again, quite a few questions around this. Would an accredited psychotherapist be able to train in CR? So again, it's the same kind of issue, as you say, in terms of different professionals and what's appropriate, and whether it should be opened out. Yeah.
Yeah, I think, if there's, I'm really encouraged that there's so much interest. And I think what I might do is actually just check back in with Linda Clare again and see if there's been any kind of formalization around the qualifications that are required to deliver CR, particularly if I'm going to devise the training for the summer. Because yeah, I mean, really there are so many people who have the skill set that should be able to deliver this, but we want to make sure as well that we're protecting the people with dementia by making sure that people are adequately trained. So yeah, I might just, in response to those queries, I might just check back in with her and see if there's anything formalized on that.
Yeah, okay, great. And if people want to come back to me, then maybe even later in the year, and I can, link in with you, Michelle, or if you want to go directly to Michelle with that question, people were asking these questions, feel free to do that. Someone has asked, how long does the CR course take to do?
The training or the actual intervention itself for the person with dementia, that's around 2 to 3 months. But the training will be a one-day training course.
Mm-hmm. Where is the training done is a question here. Now that could be either CST or CR. So
Yeah, like at the moment it's all being done online, so
Yeah,
all
yeah.
virtually. But what we used to do is, Engaging Dementia they facilitate the training for me. So they would set up a training in a hotel somewhere, depending on where the demand would be, whether it would be in Galway or Sligo or Dublin. And then sometimes, so the likes of the training that I did in Our Lady's Hospice, that was in-house. So they organised the training, and then I came in there and did the training for them there. So it can be on site, in-house, or it can be something that's organised by Engaging Dementia. Yeah, but for the moment, it's actually kind of handy at the moment as well. The access is easier because it's all on Zoom.
Yeah, yeah, absolutely. Yeah, someone has come back about that question about how long is the course. They meant to say CST actually. So how long would the CST? I think you might have said that earlier.
Yeah, so the CST would typically be delivered, for the intervention itself would be twice a week for 7 weeks, 14 sessions in total. So it's either sort of 7 weeks or 14 weeks.
Yeah,
But the training course to train a facilitator in CST is a 1-day training course.
is
So
one day training
both
course.
CR and CST, they're both 1-day training courses
Okay,
to become a
great.
facilitator.
That's great. So that's all the questions. So thanks very much, Michelle, for answering all those, and thanks for all the questions people come up with. What I might do is just launch a poll here just to get some feedback from you, if people want to say how they found the webinar today. So it's always good to, to get some feedback from people in terms of how they found things. And while that's going on, I might just show a slide for the next webinar that's coming up. Excuse me. So that's going to be on the 5th of May. It's actually on a Wednesday this time, because I know all our webinars so far have been on Mondays. So just to take a note of that, it's on a Wednesday. And it's what can neuroimaging tell us about brain health? And it's going to be presented by Dr. Robert Whelan from Trinity College Dublin. So there's still tickets available for that. So if you want to go back into the Eventbrite site that you booked this webinar through, you can book tickets for that. And hopefully that'll be of interest to some of you. So I'll just leave that running for a few minutes. Okay. There's still some people voting there. So just to say thanks very much again, Michelle, for a very interesting talk today. And there's a few comments coming in saying thanks as well, and people have found it very interesting. And as I said earlier, the recording is available so people can listen back, and the presentation will be available on our website. And so thanks to everybody for joining us today, and have a good day.
Thanks very much, Carolyn. Thanks to everybody.